Good afternoon. I'm Valerie Fleischman, Senior Vice President and Chief Innovation Officer, and on behalf of the Massachusetts Health and Hospital Association, welcome to today's webinar, Groundbreaking Women in Healthcare. Just a few logistics before we start. We will be recording this session for those who aren't able to join us, and all lines are muted. If you do have questions during the webinar, please enter them into the chat below. The questions will come directly to us, and we'll do our best to address as many as we can during the session today. Following the session, we'll be sending out a brief survey and would be really grateful for your feedback. I want to take a moment now to thank MHA's 2021 sponsors for their support in underwriting this series of webinars we're hosting to bring experts to our members to address timely issues relating to the COVID-19 pandemic, as well as other important issues in healthcare. And in particular, I want to thank today's session sponsor, Dimensional Insight, a longtime supporter of MHA. We are so excited for the conversation today. We have a phenomenal group of women healthcare leaders joining us to explore the future of cancer care and informatics, how to reinvent the patient experience, and how to crowdsource global healthcare solutions. Each of these leaders is working at the forefront of innovation and transforming the future of healthcare. And to lead our discussion today, I am pleased to introduce our moderator, Kathy Susich. Kathy is Vice President of Marketing at Dimensional Insight, a software company that specializes in bringing data analytics and business intelligence solutions to healthcare. Thank you, Kathy, for joining us to lead this conversation today. Over to you now.
Thanks, Valerie. As we all know, healthcare's drive to innovation is on a steep trajectory, and many women are fueling the exciting developments. During today's webinar, we'll hear from top women leaders in healthcare about their work in innovation. Today, we will discuss their exciting projects and their implications in the field of healthcare. Now, I'm pleased to introduce our speakers today. Dr. Adrienne Boise is Chief Patient Experience Officer at Cleveland Clinic. Dr. Maya Majumder is faculty at Boston Children's Hospital, Computational Health Informatics Program, and an instructor at Harvard Medical School. And Leslie Solomon is Senior Vice President and Chief Innovation Officer at Dana-Farber Cancer Institute. And we're delighted to have you all here today, especially during this very unique time. I think the COVID-19 pandemic, while it has certainly brought numerous challenges in healthcare, has also highlighted some of the unique capabilities of our colleagues and has been a transformative year when it comes to innovation. So let's dive right in. Leslie, could you kick off our discussion of innovation today by telling us a little bit about the work you do at Dana-Farber and what most excites you about that work?
Absolutely. Thanks for asking, and thanks for having me here. Innovation happens every day in labs across Dana-Farber. In an organization like the Farber that has over 200 PIs, principal investigators, but not just any PIs, some of the smartest scientists you've ever met asking some of the hardest questions about cancer. Innovation is what they breathe. And so the responsibility that I have, along with my team of 36 amazing professionals, is to support that innovation so that we're doing everything possible to get promising science to patients. We do that by partnering. When the science or technology developed by our researchers is ready to be taken out of Dana-Farber and put into an organization that either develops drugs or technology to be manufactured and distributed to patients, it's our job to make that happen as efficiently as possible and with the right partner. There's a point that comes when the work that needs to be done to further develop the science and discoveries from Dana-Farber labs, it has to be moved into an organization that can take that next step better than we can. As an academic institution, our researchers like to ask the important questions, do the important and exciting experiments that help them answer those questions, publish those discoveries in some of the most prestigious scientific journals, and continue to move that science forward. But there comes a time when that science has proven itself out to a certain point that another organization like a pharma or a biotech might be more suited to do that next stage of work, and it becomes a little less academic. And so collaboration is key. Drug discovery and development is incredibly complex. And as an ecosystem, the more we work together, the better the chances of success. And in addition, developing the science is incredibly expensive. The only thing standing between much of the science in our labs and a new treatment for patients is time and money. So the other thing my team works on are relationships with industry and investors to help get the funds needed to support our researchers and their teams. So innovation at Dana-Farber also means developing innovative ways to fund our work. And if I have time, I can give you 2 examples of some collaborations that we've done. So collaboration is really central to our work at Dana-Farber between our labs and our clinics, as well as the broader healthcare ecosystem. We can't rely on government-sponsored research, maybe the way that things used to get done. And we need to continue forging innovative collaborations among other academic medical centers, the biopharma industry, and other research enterprises and investors. And this is how we will best accelerate lab discoveries into new treatments to help more patients. So one example is Pathways, which is a tool that was built with the expertise of Dana-Farber physicians in partnership with Philips. We help oncologists everywhere quickly identify the best treatment for an individual patient by providing a clear map with key factors to use in making clinical decisions. As you know, cancer is an incredibly complex set of diseases, and cancer medicine changes rapidly, forcing physicians to interpret massive amounts of new information from publications and clinical trials. So Pathways helps physicians sort through these deep and complex sets of information by integrating radiology, pathology, genomics, EHR data to support these clinical decisions. And this provides a roadmap for physicians to use and navigate based on data and evidence, and to reach the best possible treatment for their individual patient, backed by the power of the entire cancer community, ultimately to democratize cancer care. Do I have time for one more, or do you want to keep going?
Go ahead.
Okay. So another collaboration recently announced is a new partnership with Deerfield Management to launch Riverway Discoveries, which is a major translational research partnership to accelerate the development of therapeutics and diagnostics for cancer. Deerfield is committed up to $130 million over the next 10 years to advance research at Dana-Farber to translate scientific discoveries with potential applications for patients. So building on our strong foundation of scientific leadership, innovation, and drug development, this partnership with Deerfield and Riverway Discoveries will support preclinical development, spurring commercialization to help advance the most promising research. Advancing the drug pipeline forward more swiftly enables new treatments to be developed more quickly, delivering on the ultimate goal of improving patient care and saving lives. This is the second such effort that Deerfield did with us. Another one began in 2018 with Deerfield committing up to $80 million to create the Center for Protein Degradation at Dana-Farber. And the goal of the Center for Protein Degradation is to interrogate and advance a large portfolio of advanced targeted protein degrader targets while creating a next generation protein degrader platform. So these are 2 examples of how we collaborate to move science forward and partner with the right partners to get our science and our technology to patients as fast as we can.
Now, Leslie, if we examine the topic of innovation more broadly, what technologies do you think are having the most impact broadly in healthcare?
So we all hear about big data, AI, and machine learning. I am starting to see that the future of cancer is really going to rely on leveraging more technology, including technology around AI and machine learning, using several categories of data, for example, ranging from a patient's cancer diagnosis to the genomic profile of their cancer, to pathology, radiology results, their immune profile, and more. We can structure this data in our clinical records and tie it to a patient's outcome using AI and machine learning to efficiently capture, sort, and analyze the data. One example of this work is led by one of our faculty members, Dr. Deb Schrag, by using the PRISM framework, which is a phenomic data standard developed by Deb and others at Dana-Farber that takes unstructured data from text reports, doctor's notes in health records, and structures them so they can be readily analyzed and matched with other data. So PRISM structures the data pertaining to the patient's, like I said, pathology, radiology, imaging, signs, symptoms, molecular markers, kind of the whole gamut, and a medical oncologist assessment to create a portrait of the cancer patient's journey and identify cancer outcomes. We have a way to go, but if we can do this with enough patients, maybe hundreds of thousands, our goal is that within the next 2 to 3 years, we'll be able to tell a patient on their first visit to Dana-Farber or perhaps other cancer centers which drugs will work for them and which won't. So data, AI, and machine learning can help us make sure that we put all the patients on the right treatment the first time, which is really important. I also think telehealth is another area, and I know others today are going to talk about telehealth, so I won't go too deeply into it, but clearly COVID opened up the opportunities of telehealth in ways that many of us in healthcare have been really hoping for a long time. I read a stat recently, and I'm probably wrong with this, but I think that the patients whose doctors are willing to see them through telehealth in addition to in-person visits have higher positive ratings than those who don't, which makes sense. Now that it's here, I think we need to explore the possibilities that telehealth provides us, both from an expertise and equity standpoint. And I think about the incredible care and insights provided by Dana-Farber clinicians, especially around complex cancers. And I think, wouldn't it be amazing if anywhere in the world someone could access that expertise? And again, I know others will talk about telehealth, so I'll move on. But those are kind of the two areas that I see as ripe.
Great. And do you think there are any other areas of healthcare that will see really big breakthroughs in the next few years because of new innovations?
Yeah, I do. I think about immunotherapy a lot and next generation precision medicine. And there have been, two important revolutions in cancer care, but we're very much still at the tip of the iceberg. Today, there's only a handful of immunotherapy drugs available to patients. And for 25% of patients overall, they work and they're life-saving, and it's incredible. But for the remaining 75%, they simply don't work yet. And so we're focused on changing that by developing new immunotherapies to treat more cancers and help more patients. While we've made good progress on being able to target specific genetic mutations, and develop resistance, tumors mutate and they develop resistance. And so we need to continue the quest to find and develop the next generation of precision medicine to overcome this resistance. To succeed, we must have a cross-disciplinary approach, really applying genomic, epigenomic technologies to hundreds of thousands of patients. So we're going back to the whole big data thing, but to really understand what happens when a patient becomes resistant and how we can intervene. And so by learning more about future mutations, we can use precision medicine in combination with immunotherapy to help more patients reach better outcomes and make more cancers a manageable disease. The two other areas I see as potential breakthrough areas, one is consumer-driven healthcare. Every day we hear about new companies that are starting up to address the need for patient empowerment and empowering patients with their own kind of ability to drive their own healthcare. And so I think those new efforts paired with supportive work by payers, self-insured employers, pharma, and providers, I think that has the ability to shift healthcare affordability along with improving outcomes. And then the last one is remote care platforms and products. And those products and platforms are continuing to improve, and they're continuing to find ways to integrate into the larger healthcare system. I think healthcare at home, healthcare in other locations are going to change the way we provide and receive care. And I think that's another big breakthrough innovation that's coming faster than we think.
Great. Well, we will talk to you again a little bit later. Maya, could you start off by telling us about the work that you and your colleagues at Boston Children's Hospital have been doing over the past year and a half in response to the COVID-19 pandemic?
Yeah, of course. And thank you so much for having me, everybody. It's a delight to be here amongst such esteemed colleagues. I think this is going to be a fantastic discussion. So in terms of my team's response efforts associated with the COVID-19 pandemic, we actually started working on this pandemic in January 2020. So long before I think most Americans were aware that there was something brewing on the horizon. And for people like me who study emerging infectious diseases, that's kind of our job. Our job is to see things coming before anybody else does. And this is especially the case for artificial intelligence researchers like myself, who are trying to leverage lots of different data streams to see whether we can predict the next big one or be able to tell how at risk different groups are going to be when the next big one comes. So within the context of the work that we've been doing, it all started with trying to estimate the transmissibility potential of SARS-CoV-2 or COVID-19. Many of the folks on the line are probably now familiar with this concept called the basic reproduction number, or R sub 0 R naught, which is essentially an estimate of how transmissible a pathogen is in a given context. And when you have a new pathogen like SARS-CoV-2, that's one of the first things that we care about. We want to understand how easily it's going to be transmitted in populations. And so one of the first things that my team did is we tried to estimate what R naught was going to be for COVID-19, specifically within the context of Wuhan, China, where it first emerged. And our team was one of the first to make this estimate. We found that R naught was about 2 to 3 in that context. And what this means is that for every person that gets infected in a fully susceptible population, we expect that they will go on to infect 2 to 3 other people. But this is an average estimate. What we found over the last year and a half is that not every person goes on to transmit this disease to 2 to 3 other people. What ends up happening is that you have some people who transmit this disease to a lot of people, and some who may not transmit the disease to anybody at all. And so this is something that we call transmission heterogeneity. And this is super important because it tells us a lot about who is at risk of passing on the infection to other people. Now, many of the folks on the line are healthcare providers, and we know that within the context of our work, we come into contact with so many people every single day. And as a result, our risk of passing on a disease is higher when we don't have access to strong PPE, for example, which my colleague Julie Lynn is going to be talking about a little bit later. So within all of this context, the question becomes, how do we leverage the massive data streams that we are now producing as kind of a computing forward society to understand diseases better as they emerge, and also to better understand how to actually counteract them? And so this goes off of kind of Leslie's comments in terms of how do we leverage big data and these sorts of analytical improvements and innovations that have been made in the last 10 to 20 years to actually counteract things that are affecting all of us every single day, like the COVID-19 pandemic. So within this context, my background is a little bit interdisciplinary in and of itself. I started off as an engineer in undergrad, then went to public health school to do an epi and biostats degree. And then I finished up my education at MIT in the Institute for Data Systems and Society. And so at IDSS, the kinds of tools that we learn are very much embedded in the realm of artificial intelligence. And so my goal coming out of my training and into my faculty position was to understand, how do we apply AI methods to public health problems, especially emergent public health problems like the COVID-19 pandemic. And during my training, I had, quite a bit of experience responding to other epidemics, Zika in Central and South America, Ebola in West Africa, Middle East respiratory syndrome, which is closely related to SARS-CoV-2 in South Korea and Saudi Arabia. So when the pandemic emerged, this seemed like my team's time to really take what we'd been learning over the last several years and try to apply it to something that now was going to affect everybody. And so one of the things that we thought about was, how do we leverage these data streams that have emerged in the last couple of years to understand this pandemic better? And some of the data streams that have been particularly useful include things like mobility data from our smartphones. Many of us own smartphones. Many of us use GPS. And one of the things that has happened over the last year and a half, especially, is partnerships with these sorts of companies who are collecting these data to understand, when you have a stay-at-home order, how does that affect the way that people move around? Are some people more compliant than others? And what does that mean about disease transmission later down the line? So these are the sorts of questions that we were able to start answering concretely with empirical data the last year and a half. And that's helped us inform lots of things like policy shifts and trying to understand, when should a stay-at-home order be lifted versus remandated, for example. And as we enter the post-vaccination era of COVID-19, one of the questions has become, who should get vaccinated and who should go first? And I think that all of us are very familiar with the inequities that our vaccine rollout has really exposed in the United States over the last 4 or so months. And one of the things that my team is thinking about now is if it looks increasingly like we'll be needing booster shots and some regular interval in the next couple of years, how do we make future rollout efforts more equitable than what we have done over the last couple of months? And so this really mandates using more advanced modeling technologies to try to understand who is truly most vulnerable, not only to getting sick and dying from the disease, but also passing on the infection to other people. And trying to really leverage all of these different objectives to come up with solutions that are more equitable is something that my team is really focusing on right now. So I like to say that artificial intelligence is a toolkit, and it can be applied to a lot of different problems in a lot of different domains. But to do it well, you really need domain knowledge. You need to be embedded in systems where you are working with clinicians, where you are working with public health practitioners. And that's something that I get to do at Boston Children's Hospital. And to me, that's really, really exciting. And I think it's part of why my team has been able to be as successful as we have been over the last year and a half in terms of advising different policy solutions to this pandemic that has affected all of us.
Thank you. That's all fascinating. How do you think the pandemic changed the way that you think about innovation in your role?
That's a great question. So I think that with the emergence of more and more internet-based data, especially because so many people are home more than they used to be, the amount of social media data that's been generated, the amount of search query data that's been generated has skyrocketed. And it's really enforced this idea that these novel data streams should be informing the way that we do public health response, not just to COVID-19, but to lots of different public health problems. And I think that's another thing that COVID-19 has exposed other public health problems. It's not just COVID-19. So we have an epidemic of racism in this country. That's a very real public health problem in that it affects the longevity of minoritized groups. Then we have other issues such as the mental health pandemic, which is something that's emerged and has really, I think, been exacerbated by the COVID-19 pandemic due to financial loss, due to loss of life in people's families, due to the simple changes in our social structure, the fact that we live our lives very differently now than we did 2 years ago. And so these sorts of related pandemics, in a way, in that they have been really, they've kind of had a spotlight turned on them because of the pandemic, have also really kind of informed my group of the fact that the data streams that we are using to understand COVID-19 better, they can be used to understand other public health problems better too, and to monitor them and hopefully mitigate them. And I think that, to me, that's really exciting. So figuring out how we can leverage these other data streams, especially the data streams that have seen an uptick in volume due to the fact that people's internet usage has changed drastically in the last year and a half, is something that I am personally really interested in kind of carrying forward and seeing how much further we can innovate in this space, not just within the context of responding to COVID-19 directly, but also responding to the myriad other public health issues that have been exposed by the pandemic.
And what technologies do you think hold the most promise in impacting healthcare moving forward?
I'm biased, obviously, as an artificial intelligence researcher. I think that there is such a huge future in terms of seeing how we can use AI methods and approaches to really understand these public health problems better, and more importantly, to respond to them and to address them. But I think that, again, I'll emphasize that the importance of domain knowledge really can't be overstated. So as excited as I am about bringing the methods and tools that I've learned in my training to these problems that I think are so vitally important to society, I think that more and more what we need to be doing in terms of training our AI researchers, so folks like me and folks like my trainees, is really help them get embedded in the systems that they will be trying to craft solutions for. So this idea is, if you're studying computer science and you want to use artificial intelligence methods to make the world a better place, or AI for social good, as we call it, then you need to pick a domain and you need to embed yourself in that domain. So if that means that you want to make a difference in healthcare, that means really seeking out opportunities in the healthcare system so you're surrounded by people who understand this domain much better than you ever will, much better than I ever will. So you can really actually start to address the problems that matter. So this is one of the things that has emerged repeatedly, at least in AI research, is that, we want to craft solutions and we love fixing problems and solving problems. I think that's very much what computer scientists and engineers are kind of geared towards in terms of our mentality, but we need to pick the right problems. And I think that's where domain expertise is so vital, because not every problem is worth solving right away. And there are some problems that really need to be solved yesterday. And I think that that's where AI, as innovative and wonderful of a toolkit as it is, really needs to start thinking as a domain itself, how to integrate itself with other domains where we wish to apply the work that we've been doing methodologically to spaces where we might see a big difference if we work together with clinicians and public health practitioners and so on and so forth. So I guess my answer is I'm super excited about artificial intelligence and its future in terms of healthcare innovation, but the caveat is AI researchers need to really be embedding themselves in healthcare systems so that we choose the right problems to solve and that we're context specific and context sensitive to those problems.
Great. Now let's move on to Adrian. So Adrian, in your role at Cleveland Clinic, you sit at the intersection of innovation and patient experience. Tell us how this human focus impacts how your organization thinks about innovation.
Sure. Hi, everybody. Thanks for having me. I appreciate being on with these groundbreaking women. It's very exciting and to be included. So I think, innovation to us is innovating for people with people, in my mind. I have the privilege of seeing a lot of the pain points that our patients have across healthcare systems. And it's very interesting. When I talk to most people in healthcare, they're all talking about innovating in the clinical care domain, which I think is critically important. The problem I see with that exclusively as an approach is that the pain points for patients really don't have anything to do with the clinical care. The pain points for the biggest pain points, I'm making a generalization, but the biggest pain points for patients are actually around things like accessing your services, communicating with their doctor, the billing experience, feeling like their family member wasn't engaged. And these types of problems are equally ripe for innovation. And so the highlights, to be fair, and even that it's Nurses Week, the highlights of people's experiences are the people. So I have no doubt, right, Dana-Farber, Harvard, Brigham, these are places with extraordinary people, clinicians, transporters, everybody who's taking care and showing up because this is part of their purpose. And patients see that. You see the highest ratings of how doctors and nurses communicate, and that is a powerful driver of the likelihood to recommend that service, as well as teamwork and empathy and ease, which we've spent a lot of time talking about. So, how do we think about that? Well, we listen to all of that. So we're applying natural language processing sentiment to all of the feedback we get from patients so we can create a more comprehensive view of the patient journey, not just in a singular moment, but across their journey. We go out and actually round regularly. We have all of our board members round with us to actually go talk to people. A wild concept, right? It's like to go talk to people out where the work is done to really get a sense of this great, we talked about that over there, or this was the beautiful polished report I got, but how's it really going? And what are the barriers that you see day to day? As a means of informing what we solve for and where our attention is dedicated. And I think that's where the best ideas come from, is that, of course, the people doing the work or the people who are on the receiving end. We also partner, so important to comment that we have hundreds and hundreds of patients and families that we bring on as healthcare partners that do the work with us, to sit on our data governance committees, to think about how the ethics of AI, right? So that as we innovate it, we're co-creating that innovation with the people, not just our caregivers, but patients and the ones who will be most impacted by it. And I would say the other thing that I've advocated for strongly for anybody who knows me is the idea that we have to innovate around how we measure experience. We're a bit in the dark ages. We need to move into point of service, omni-channel understanding of that. And also, to be quite honest, if you ask about someone's experience and we're not able to resolve it in the moment, we should just stop asking. And instead wait to hear 2 months like we currently do, to hear how is it going. We have to kind of innovate in that space too. So those are some of the things that are top of mind for me.
Great. Now, when you and I first spoke a couple of weeks ago, you shared with me a very powerful story about one of your patients and how that illustrates what we should be focusing on in innovation. And I'm wondering if you could share that story with everyone right now.
I'll try to. It's a hard story to share. And I think drives home the point I was just making that I continue to practice. I'm a multiple sclerosis neurologist, part-time ethicist and full-time chief experience officer. And I continue to practice because it teaches me and humbles me quite honestly every day about, again, the settings we're in. The boardrooms are different than what some real people experience. So the story I had shared was about a young man, early 40s, we'll call him Roger, who had actually worked in a factory and had this amazing wife. The first time I met him, actually, they had been ping-ponged around for probably about 1.5 years. Between physicians and referrals, from spine to ortho to neuro to primary care to, it just was like an incredible story when you listen to how long it took for him to get to me. And the only reason he got to me was because someone who I had trained with saw him in a spine ortho clinic and said, this has nothing to do with me, you need to go see Adrian. And regardless, the first time I met them, they were the couple you watch that they've been together so long, they were high school sweethearts, and they're like pinging back and forth at each other, real sarcastically, but it was sort of this beauty in their love. That's how they loved, was to argue. And I remember thinking, God, we're gonna hit it off great, because I tend to be a realist and enjoy sarcasm. And he had, unfortunately, extensive damage to his spinal cord as a result of MS, a pretty aggressive MS. I chose the top-notch treatment for him, which had risks to it that were pretty significant. And we had to talk about that. And I remember him saying, if something bad could happen, it's going to happen to me. And I hear that often. And so we talked through that. He's like, ultimately in the end, he's like, I trust you. So I put him on the treatment and things seem to be going fine. Next thing I know, his wife has apparently told one of our clinicians that he is bumping into things on one of his sides. I can't remember which. And he got admitted to the hospital and ultimately was diagnosed with this very rare infection that can occur with this treatment. That he was afraid he would get. And we spent time talking about it. It's called progressive multifocal leukoencephalopathy, fancy name that just means an opportunistic virus invades the brain. And he was significantly disabled. He couldn't see out one part of his visual field, one part of his body didn't move anymore, and it rapidly progresses. I go to see him in the hospital and he's weeping at the bedside. And I thought he was really sad about this diagnosis. And I went in and sat down next to him. I said, what's going on? I know this is really hard. And he said, he looks at me in the dark with tears streaming down his face and says, my son was just murdered. And I fell apart. I just started crying, sitting on the bedside with him. And I just couldn't imagine that this was really happening. And so I sat with him for a few minutes and then I walked out and I called spiritual care and healing services, maybe for him as much as for me. To fast forward the story, we flu is set up, his son did pass, and probably 2 years later, fast forward, and he can't get home care in his home to take care of him because they don't have the right insurance, and his wife works. And then 6 months after that, his house burned down and he was unable to replace his wheelchair in a timely fashion. And like, I'm laughing because it's so sad. I don't know what else to do. But this can't be the journey that any patient has. I recognize bad things happen and healthcare can't make them worse, right? And that's what is happening. Whether it was the access problem, these are the things that I need in my home to take care of myself and you couldn't get them. Whether it was he's 3 hours away and transportation is an issue and virtual doesn't work for them. We have to design for the people we serve. And for some people, these super cool things will work and for others they won't. But it doesn't mean that we should forget. So I carry him he just got COVID. So it just expands your heart capacity and fire, quite honestly, in my belly. I mean, this is about groundbreaking women. I don't know if I'm a groundbreaking woman, but I got this fire in my belly that story makes me mad. And I wanna change the world because of it. And I think everybody on this webinar, I think has the same fire. I hear it in different ways.
Thank you for sharing that. Now, Cleveland Clinic was one of the early pioneers in telehealth even before COVID-19. How are you able to leverage that early investment during the pandemic and take patient care to the next level?
Thanks, yeah. The traditional ways were through virtual visits. We were doing probably 5,000 a month prior to it had been building to that, change management. I'm looking at Leslie, there's change management to get people to use these different tools for about 6 years probably. And our CEO was also a big proponent. So that amped up, obviously. We went from 5,000 a month to 200,000 a month at its peak, probably last spring. We launched digital engagement plans for patients all around COVID so that we could connect with them and care for them without them having to come in. So touches every day and, counseling about mental health and making sure those check-ins were humanized where they needed to be and digitized where they could be. Which is an important design component to these tools. We virtualized essentially everything from advanced care planning, spiritual care, funerals, baptisms, music therapy, art therapy. I mean, there was really just no limit to what we were willing to do. Another sort of more common across hospitals was the visitation, the use of FaceTime, Google Duo, whatever it took to get visitors in when they weren't allowed to be at the bedside. That continues to this day. We bought, I think, 600 iPads in the span of 2 weeks to make sure that was possible for patients and families. We tried, I would say, non-digital ways. We also tried to leverage, volunteers in different ways. Could they make videos of how grateful they were for the care they were getting, setting up kudo boards for the organization for people to just write in and post notes so that caregivers could see that when they walked into the organization. We got volunteers to write letters to the units and then deliver them in big bags so the units could know how much they were appreciated, and to patients in the units. And 24/7 care, I think, critically important. We had that standing up as a platform, as well as online second opinions that Leslie was referring to, right? Like, you can access our expertise in whatever way you want. Someone's calling to get that now. So, again, there's no end to the possibilities, and I think making sure we're that can also hurt us, right? Everybody wants to do everything as quick as they can, and as Leslie mentioned, everybody's an innovator in healthcare. It's great. We do need to make some priority decisions about where we're going to invest time, energy, and why. What are we measuring to demonstrate this is really having the impact we think it is an important. Less attractive, but really important question to be asking as these things come down the pipeline.
Thank you. And then Leslie, if you could take this question, how are you incorporating health equity into your work?
Yeah, thank you for asking. We're actually thinking about this across many different areas. In fact, we realize that we need to be in the community kind of more than ever before, and health equity is very much a part of that. Across the entire institution now, we have an effort focused on reaching out to communities of color, BIPOC, but also internally, we are incredibly focused on educating our workforce. I'm actually an executive sponsor of the team that's focused on education. So we are thinking about that from that perspective. And then lastly, what I think is really important too is how we are. So we also have the Dana-Farber Harvard Cancer Center Office of Cancer Equity and Engagement. And so through that, we're also developing and implementing tools to understand and monitor the cancer burden in Massachusetts, but also to create and enhance partnerships with communities to address the cancer burden. So again, outside of our walls in the Longwood medical area, and particularly cancer disparities. Also important that we're thinking about is we're increasing access to clinical trials among underserved and minority communities in Massachusetts and maximizing the impact of our research. So we need to make sure that we're informed by the community needs and in both communities in Massachusetts and beyond. And just one example is that we recently entered into an agreement with Boston Medical Center and Mass General Hospital as well by working closely with the Boston VA to improve access to clinical trials to more patients of color.
Great, thank you. And thank you all for your tremendous insights. Thank you to all our attendees for joining us for this hour. I honestly think that we could have spent an hour with each of our guests. This was fabulous. I'm now going to hand it back over to Valerie to wrap up.
Thank you. Thank you again to our terrific panel of speakers. Thank you, Adrienne, Maya, Leslie. The work you're doing is so inspirational. And thank you to Kathy for leading such a far-reaching discussion today. If you enjoyed today's conversation, please save the date for two of our upcoming conferences, one on emerging technologies and innovation coming up in June, and our annual Women's Conference on November 11th. We will be sending out an evaluation of today's session and really would appreciate your point of service feedback, taking the phrase from Adrienne. Thank you all for joining us and hope you have a wonderful afternoon ahead. Thank you.